Good morning, everyone. Today in our project echo session, I will request Dr. Avais Masud to walk us through the renal stones. To me, this is a difficult topic to understand sometimes. So I rely upon Dr. Masud's expertise to guide us as how to approach this situation. So go over to you, Dr. Masud.
Thank you, Umar. Thank you, everyone. Yes, it's a kind of interesting topic. And management of kidney stones also kind of interesting. The reason being that if you go by recent history, about 40, 30 years ago, the urologists used to take care of everything about kidney stones. They used to do metabolic workup and then treat medically because they did not have any procedures to do with. But with passage of time, they developed new procedures, lithotripsy. So their approach, like a medical management and evaluation, went, on the backside. And nephrologists, not all the nephrologists are well trained in their nephrology program to manage a kidney stone medically. So it's not like not too many people who manage this medically from nephrology point of view. So luckily, during my fellowship, my mentor, program director, Dr. Anton Schoolworth, I learned two things from him, something interesting kidney stone and running marathon. So I end up doing both. So I have some interest. I'm not expert. I don't claim myself an expert in kidney stone, but whatever practice I have experience, I will share with you. I will keep it simple. And after that, if you have a question, I think I'm more looking forward to talk about any questions. And in next session, I will bring some cases. And if our colleagues have any patient, we can discuss. I think we're going to learn more from those patients. So let me start. Again, I'll be very make it simple. So kidney stone is a common problem. And I know the epidemiology is different in Pakistan. Here in America, is white are more commonly affected as compared to African American. And then this is the basically like a percentage of kidney stone. So this is probably different in Pakistan. But I expect that it's a very common problem in Pakistan because climate is dry and hot. And so it's common, probably more common than US probably. But still it's a major medical issue and surgical also. It's increasing kidney stone formation even in America. If you go by about 20, 30 years ago, at that time, like there were 7% or 8% population had history of kidney stone, but now it's more. And most important factor is the obesity, because now we have weight gain has increased over a few decades, and same is the prevalence of kidney stones has increased. And again, with the obesity and comes with diabetes and metabolic syndrome that increase the risk for kidney stones. And there are different types of kidney stones. The composition of kidney stones, most common are calcium stones and particularly calcium oxalate stones. And then comes calcium phosphate stone, mixed stone, uric acid stone. Then we have an infection stone called struvite stone and cystine stone, which are not that common. Again, that different in different countries. I don't know, uric acid stone, I know that in Middle East, very common, probably the commonest cause of stone. In Middle East, I don't know about Pakistan. I tried to look at their data, but I couldn't find. So if you folks have any idea, I think you can share with us also. So again, the primary cause of kidney stones are when there is crystal formation, when there is a crystal forming ions like calcium or oxalate. If they are less in number, their saturation is not that high, and less saturation, then they would not find any kidney stone. When the saturation increases and it goes to crystal growth, and when the saturation also increases furthermore, then cause the crystal nucleation forms, and then the other crystal built on that. For example, calcium oxalate stone, the nidus is most of the time is formed by the uric acid. And then calcium grows on that nucleus, and that makes the kidney stone calcium oxalate stone. So, but saturation is not the only factor. There are some factors also influence the formation of kidney stone. There are some inhibitors in the urine naturally, or in the diet, which prevent even the saturation is above the regular level. So there are many inhibitors, but most important one is citrate. We're going to talk about that. Others not that important, but citrate is the most important inhibitor for the kidney stone. So the major risk factor for calcium stones are urinary when the low volume, that's no-brainer. And when there's the high calcium in the urine and high oxalate in the urine from calcium oxalate stone. And the low citrate is the inhibitors. When the low citrate in the urine, that can increase the risk for calcium oxalate stone. And when the urine pH is high, that increases the risk for calcium phosphate stone. And those are the urinary factor. When the anatomical factors, medullary, sponge, kidney, and horseshoe kidney, that increase the risk for kidney stones. And diet is also a factor. When the high oxalate and the low fluid intake, that's commonly when there's a high sodium, that's a very important factor. People who have increased sodium intake, that increase urine sodium, that drags calcium with that, so that causes increased calciuria. And that is a very significant, perhaps one of the most important risk factor for kidney stone formation of high urine sodium. Vitamin C, we neglect. I've seen like my patient, when commonly I went over their medication, they say, oh, we're taking vitamin C, 500 milligram twice a day. I said, why are you taking it? Then somebody told you? They said, no, since I've taken, I have no flu. I think this is good for prevent any flu or any infection. But I told them that high intake of vitamin C can increase the oxalate level and can increase the risk for calcium oxalate stone. Again, perhaps the most important factor in forming calcium stones are the increased urinary calcium. You can see that from 3 big studies, as the urine calcium increase, same is the risk for calcium oxalate, calcium stone, calcium oxalate, and calcium phosphate both. So this is a relatively like a 200 level. If you see that if the urine calcium in 24 hours is less than 200, the chances of having calcium stone is low. But as the level increase more than 200, the chance of getting calcium stone is high. So hypercalciuria is a very important factor, perhaps the most important factor forming kidney stones. So hypercalciuria, there are 3 reasons for that. Perhaps the most important one is when there's increased absorption of calcium in the gut. So increased absorption of the calcium from the jejunum and ileum, and that increase the serum calcium, that decrease the PTH from that, and increase urine calcium. And that increased absorption is familial or genetically, and without going more details, there probably is the increased receptors or whatever reason that they increase vitamin D receptors, so that increase the calcium from the jejunum or ileum. There are other forms which cause renal hypercalciuria, like a renal calcium leak. That means that patients are increasing without having, that's a negative calcium, that patient increase the urine calcium, so they decrease calcium reabsorption in the proximal columnar tubules. So in that case, your serum calcium will go down. That will increase the PTH level, okay, and increase urine calcium. So, and the third one is when patient has primary hyperparathyroidism, that will increase the bone resorption, calcium resorption from bones, and try to increase calcium in the blood, and also increase calcium in the urine, and that increase the because of the increased vitamin D level. So these are three causes. Most commonly, we see that absorptive hypercalciuria. So there are different type of crystals. These are calcium oxalates. So hyperoxaluria is of two types mainly. One is when there's an increased absorption from the enteric, from the gastrointestinal tract, called enteric hyperoxaluria. When there's an increased absorption from the different cause for that, then the gastric bypass or there's a Crohn's disease or any other GI condition, which increase the absorption of oxalate. And there, the primary hyperoxaluria, which is of three types. I will not go into detail about that, but these are basically some genetic mutation, which have some abnormality enzymes that increase the formation of oxalic acid from the liver. So we commonly see patient has enteric hyperoxaluria. So what happened that there's increased absorption of the oxalate from the intestine. The reason, let me go. I'll go in more detail in the following about that. So this trial shows that the gastric bypass surgery on kidney increase the formation of kidney stones. So basically, there are different type of weight reducing surgery. Gastric sleeve does not cause that much, but this is common, like doing by gastric bypass surgery that increase the risk for oxalate stone more than other surgeries. This is for primary hyperoxaluria. There are three types, 1, 2, and 3. Primary hyperoxaluria 1 is the most common one and the most serious one, and that increase the formation of oxalate from the liver because genetic disturbance or enzyme abnormality, they increase the LDH formation, and that increase the conversion of, rather than some other product, increase to oxalate, and oxalate cause the calcium oxalate stone. And actually, when the kidney failure eventually happens, the oxalate are deposited in different organs, including heart and other, and cause a life-threatening situation. So just to remind that the treatment for that, as for the transplant is concerned, is a liver transplant, because not the kidney transplant. If just kidney transplant will be done, the primary abnormality is still there, which is increased formation from the liver. And so treatment for that is liver transplant, not the just kidney transplant. But luckily, we have some new medication available now, which have significantly decreased the formation of oxalate in a patient with the primary hyperoxaluria also. And so that is very promising. So uric acid stone is prevalence is increasing now. The risk factor of people who have a gout or myeloproliferative disease or genetic disorder that form more uric acid in the blood, and that goes to urine and form the uric acid stone. Metabolic syndrome, which is getting common in all over the world now, that increase the uric acid production, and urine pH is decreased in that case, that increase the risk for uric acid stone, because decreased urine pH is a risk factor for forming uric acid stone. And people who have, patients who have diarrhea and low fluid intake, diarrhea causes metabolic acidosis, decrease the urine pH, that's another risk for increased uric acid stone. Or uric acid stone risk can also increase the risk for calcium oxalate stone, because most of the calcium oxalate stone has the nidus of the uric acid in that. So treatment we'll discuss a bit later, but again, alkali or antacids to increase urine pH is a very important factor in medical treatment for uric acid stone. Obviously, other factor of weight loss and increased fluid intake is also important. So this is a different cause of, in different situation, when you have increased risk for uric acid stone, like diarrhea, you have low volume, low urine pH, and hyperoxaluria. Then myeloproliferative disorder, you have again high uric acid. the blood, high protein, animal protein that also have caused low urine pH because of increased sulfur in the urine, and that because of the metabolism cause hyperoxaluria and oxaluria also. Same that probenecid, other medication which are uricosuric drugs, which increase the uric acid excretion in the urine, so that increase risk for uric acid stone. Same as gout and the metabolic syndrome we just spoke about. So again, the same thing, that increased weight gain is increased risk for uric acid stone, which has been increasing over a few decades and continue to increase. These are not just a diabetic patient, but also non-diabetic also. So you can see on the left side of this that these are non-diabetic, and look at the BMI. As the BMI increased, the prevalence of the uric acid stone increases, and similarly, patients who are diabetic even more. So increased weight gain and increased BMI has increased risk for uric acid stone. Similarly, protein load. People who eat a lot of meat, and that increase the uric acid level also. Increase risk for that increases sulfur, that increase the urine pH, and slightly increase metabolic acidosis, very slightly, and then and also decrease the urine citrate level also. So at certain level, that more than that, increase the animal protein, increase the risk for urine stone, particularly uric acid stone. Then we have, luckily, not that common, but when we have infection associated kidney stone, they are serious, very difficult to deal with. So these are struvite stone. So these are bigger, multiple, and they need both surgical medical management to deal with this. Very difficult many times. So more common in females because they have more prevalence of UTI and more in extreme ages. And if there's a congenital urinary tract malformation, and people who have like more stasis of the urine, like neurogenic bladder and chronic indwelling catheter, those people have more risk for struvite stones or staghorn stones. So just to make clear that there are many bacteria which causes a UTI, because urea's forming bacteria that cause urea's formation, and that increases risk for staghorn or infection stone. But E. coli, which is a common cause of UTI, is not among those bacteria. It does not cause ureas. Cystine stones are not that common, but they're very like distinct crystals they have, hexagonal. If you see that or are seeing that, that's pretty much diagnostic of cystine, urea cystine stones. They are developing acidic urine. So this is basically, again, an inborn error of cystine metabolism, which causes cystine. There's an amino acid cystine in the urine that cause cystine stones. So once we have a patient with recurrent kidney stones, or not recurrent, I mean, sometimes if you have bilateral kidney stone on one time, patient should be evaluated for what is the metabolic abnormalities causing kidney stone and how we can manage that. So who are the patients who commonly need that? Patient who has recurrent kidney stone formation, patient who have strong family history of kidney stone, or have chronic diarrhea or other condition which make them having increased risk for kidney stones. So those patients need to be evaluated for metabolic abnormalities causing kidney stones. So obviously they need to complete metabolic workup, like a complete metabolic panel. Urine should be checked. Urine pH need to be checked. And if possible, the analysis of the kidney stone, if that is caught. And obviously, we talk about the 24-hour urine. That is the best way to find out the cause of the kidney stone in that particular patient. This we normally do here in US. I'm sure the different mechanism of doing 24 hours, different reporting in Pakistan. Here's just one example. Like I normally ask patient to do it 2 times, so that increase the better way of looking at the abnormalities. So this is a one patient example. The volume in 24-hour is not a bad volume, but like to have more please. But 2.35, this is not too bad. But this is like supersaturation of calcium oxalate stone. This actually is a computer-based analysis of the increased saturation of that patient, depends on their calcium and oxalate and the way how much patient has risk for that, how much is supersaturation. Obviously, increased supersaturation put patient increased risk for that particular type of kidney stone. So this patient, you can see that very high supersaturation for calcium oxalate stone. So this patient has increased risk for that. And we can see the reason this patient have calcium 24 hours very high, 375, and the second time 423. Very high urine calcium, hyper calciuria in this patient. Also have increased urine oxalate, not terribly high, but definitely high, 5261, that's high. And the citrate is normal. This patient would like to have even more citrate, higher. And this patient have not that much supersaturation for calcium phosphate stone. So this patient has increased risk for calcium oxalate stone, not calcium phosphate stone. And look at the pH. pH is more acidic, so that is increased risk for calcium oxalate stone, but not calcium phosphate stone. So this is a very helpful 24-hour urine test. Every patient should be done who is candidate for metabolic evaluation for kidney stones. Kidney stone analysis also, like majority of time, patient not able to catch the kidney stone, and we assume or we have better idea or some guess that what likely form of kidney stone they have. But if they're able to catch a kidney stone, that is sent for kidney stone analysis, and that gives an idea that what their kidney stone they're forming, and you can adjust your treatment accordingly. The different way of technology of doing kidney. This one is micro CT of like this patient has mixed stone, uric acid stone and calcium stone. So obviously it's no-brainer. Everybody knows that patient who have kidney stone former, they need to increase their urine output. And the urine output should be at least 2 liters, if not 2.5, which is not easy. I mean, general people who don't have commonly more than 1.5 liters of urine in a day, but those patients who have kidney stone or risk for kidney stone, they should have increased urine output. So this is the goal, at least 2 liters, but 2.5 would be better, or even 3 if they can manage them. So patient very commonly ask that what kind of fluid they should. I encourage them to increase the fluid intake. Better anything okay, because you have to increase the compliance also. Just water, some people don't like to drink water, but some they should avoid. Particularly Coke, like a colored Coke, like a dark Coke, because it has a lot of phosphate in that. And so again, sugar sweetened soda, those they should avoid that. And cranberry juice, they very commonly women use it to for UTI, but that actually has decreased urine pH and actually have oxalate also. So generally it's okay, but for stone forming people, that's not good. Orange juices, there used to be some studies that it has increased oxalate, but later studies show that no, it does not. It has a lot of citric acid, so they can and they can have it. Common question, can they have coffee or tea? Again, if you go by old study, they said they should avoid tea and coffee because it has oxalate, but later studies shown that no, nothing wrong with the tea and coffee. Actually, it is to some extent is protective because of their ureteric effect. Those people who drink coffee and tea, they urinate more as long as they're able to rehydrate themselves, and the urine is diluted, and to some extent, tea and coffee are protective. Okay, treatment. There are three main medication for treatment. These are three medication. Most important one is thiazide diuretics to treat hypercalciuria, which is probably the most common urine abnormality in patient who form kidney stones. And then we have a potassium citrate. Citrate is an antacid for urine. It increases the urine pH for most of the patient with kidney stone formation, except patient who have calcium phosphate stone, because in that case, you don't need to increase, actually, to decrease the urine pH, or patient who have infection stones. And xanthine, like allopurinol, or those patients who have uric acid stone, they have increased uric acid, or they have increased serum uric acid, they need to be treated by xanthine oxidase inhibitors like allopurinol. So these are the different medication, thiazide diuretics, and recommended dose to prevent hypercalciuria. This is a very good combination, amiloride and hydrochlorothiazide. I use some of those patients who just not responding enough with the thiazide diuretics, because amiloride also increases or synergistic effect in decreasing the hypercalciuria. So goal is to keep the urine calcium less than 200. So when you see that sodium restriction is very important, as we spoke earlier. So they should not decrease their calcium ingestion. They should not be on low calcium diet that actually increase the risk for calcium oxalate stone. They should have moderate or slightly on the high side calcium ingestion. But one thing is important, how they take the calcium. If they're taking calcium by dairy product like yogurt or cheese, that is very helpful, because those type of calcium, they absorb oxalate in the stomach or gut that decrease the absorption of oxalate. But if they're taking just a calcium tablet at empty stomach, that will not go. That will actually increase the absorption of calcium. So that should be discouraged. But if they have to take calcium supplement, they should take at time when they're eating food, like the dinner time or lunch time, they should eat with food, but not empty stomach. That's important. So obviously then the thiazide diuretics that decrease the hypercalciuria, it has some side effects also. Thiazide diuretics, like it can cause hypokalemia that need to be treated very aggressively. Hypokalemia increase the citrate absorption in the proximal pulmonary tubules, and that decrease the urine citrate. So hypokalemia caused by thiazide diuretics need to be treated very aggressively. At the same time, thiazide diuretics by itself decrease the citrate, urine citrate level, but that has to be compensated. The patient should be taking most of the time both medication together, like thiazide diuretics and the potassium citrate. So low citrate level is the very common cause of kidney stones. So that need to be aggressively replaced by potassium citrate. And if patient have a CKD or some other reason to risk for high potassium, then we have other options also. Not the best option, but you can have a sodium citrate or even calcium citrate or magnesium citrate. But the best is a potassium citrate if patient potassium can be managed, because sodium citrate has sodium in this, and that can increase the urine calcium. and how the citrate decrease the risk, decrease risk for both calcium oxalate and calcium phosphate stone, because they bind with calcium and then decrease the formation of calcium oxalate stone and calcium phosphate stone. Renal tubular acidosis, distal renal tubular acidosis is a high risk for kidney stone, because it increases the urine pH, which increases the risk for calcium phosphate stone, not calcium oxalate stone. So distal RTA, about 70% of the patients who have distal RTA, they have some level or more or less some degree of kidney stones. Again, calcium phosphate stone, not calcium oxalate stone. So we spoke about that enteric hyperexuria, and a slide came late. But anyway, what happened that when there's an enteric hyperexuria, when there's a like malabsorption of, because of whatever reason, that Crohn's disease or other enteric condition, then calcium is basically calcium is with the fat. It actually combined with fat, and calcium is there's not much calcium left to mix with calcium oxalate, because otherwise calcium oxalate is formed in the gut and that will go to stone. But when there's not calcium available to combine with oxalate get absorbed and goes to urine and cause increased oxalate in the urine. And when there's an increased fatty acid because of whatever condition, fat malabsorption, that actually increase the absorption of the oxalate from other mechanism also. So then decreasing the amount of fatty acid in the intestine is like by chlorostyramine or some other way, it's effective treatment to decrease the absorption of oxalate. Yeah. So when there's a fatty acid and combined with fatty acid, so we just spoke about. So treatment hyperoxaluria is low oxalate diet, which is basically it's hard to, because every food has oxalate. But if you have to tell them that avoid one food, which that is spinach. Okay, that has probably the highest oxalate level of all the foods we consume. Then some other commonly, like some nuts have high oxalate, but not all the nuts. Like peanuts are a little bit more, but some other nuts like pecans, they have low oxalate. Actually, I like nuts, so some are low oxalate. Thank God I never had kidney stone, but still I like to avoid having any. And there are low oxalate nuts available, which you can have that. They can enjoy that. Again, vitamin C. High dose is not good. Increase the level of oxalate. Actually, there was a case report. A patient who was taking a very high dose of nuts every day and ended up having oxalate and nephropathy. So that need to be keep in mind. So patient, when taking calcium supplement, they should take with the food, not empty stomach. And they should not decrease their calcium intake. That's important. And then I say that bile acid secretion like cholestyramine, those patients who had the malabsorption, they should use it. So primary hyperoxaluria, I don't want to go in detail. That is basically some genetic disturbance, abnormality, when they have increased oxalate production from the liver. And those patients have some medical treatment available now. They also should be given vitamin B6. Okay, that actually decrease the production of oxalate, and some other medication. I think Lumisaran, that is available now, very effective. Okay, uric acid stone. There basically, it's not good to have any kidney stone, but if you have kidney stone, the uric acid stone are relatively easy to manage, because they are the only stones which actually can be dissolved if you increase the urine pH. Other stone like calcium oxalate, calcium phosphate stone, you cannot dissolve it. You have to manage. You can treat them to lessen their risk for increased formation or growth. But uric acid stone actually can be dissolved actually. Again, increase your urine output by increased fluid intake, decrease animal protein intake, and increase the urine pH by fluid or citrate, by oral medication like potassium citrate, or by fluid or lemonade, which has very good source of citrate. And if you have metabolic syndrome, try to decrease weight, weight loss, increase activity and glucose control. That is decrease the urine. I mean, that increase the urine pH and decrease the risk for uric acid stone. Same thing. Increase the urine pH, but not too much. Keep it less than 7.0. Ideal urine pH is between 6 and 6.5 for those patients. And if patient has needed, they can have either allopurinol or Uloric. It comes like this is a febuxostate. There has been actually study which shown that febuxostate or Uloric decrease the uric acid more than allopurinol. So just one study. Very expensive. Cystine stone are less common. The fluid intake should be increased, and this actually very more actually than any other form of kidney stones. Sodium restriction important, protein restriction important, and urine alkalinization is very important. So if you have to prevent the formation of cystine stone, you have to alkalinize urine far more than other like uric acid stone. And that's the only time when you can use carbonic anhydrase inhibitors to increase urine pH, because it's not otherwise possible to increase urine pH where you desire, where you can restrict the formation of cystine stones. But there are some medication available also. This is a alpha mercaptoparagline, and also luckily I didn't have a case as yet, but theoretically these are two medications available. D-penicillamine, which has more side effects as compared to other medications, so there are medication available for cystine stone prevention. So this is a very problematic, and I am sure that many of you have dealt with that. Those patients who has infection stones, these are big, they are very like a life is affected from the most of the females who get it, and that actually needs a good coordination between urologist and nephrologist to take care of that. So these are, as I earlier spoke, these are gram-negative bacteria, which are urea-splitting organism, which increase the ureas, and that form the ammonium, and that increase the steroid stones formation. So those patients need surgical treatment and also need prophylactic or treatment with antibiotics more for a long period of time, commonly Bactrim or nitrofurantoin. And there is a medication also available, lithostat, that also prevent the formation of ureas, and that simultaneously need to be taken by patient with antibiotics and lithostat. So what you have, how you treat when patient comes to you, when patient has kidney stone, what you do. So how you evaluate. So if patient has no contraindication from CAT scan, patient is not pregnant, so CAT scan is better to than ultrasound, particularly for ureteric stones. But some recent studies shown that ultrasound is actually same effective or sensitive or specific, but more studies shown that for ureteric stone, CAT scan without contrast is better than ultrasound. Okay, so patient comes with a kidney stone, with the pain management. Okay, in that case, the patient has no contraindication, non-steroidal are better option than opiate. If patient has no contraindication, no chronic kidney disease, so they should have that. And if patient has pain is manageable, then patient can be discharged if you see in the office or hospital. But if pain is too much, or patient has infection or acute kidney injury from that, obviously then patient need to be admitted. If that's not the case, the patient can be sent home, observation, and depends on the kidney stone also. And if patient has kidney stone sizes between 5 millimeter and 10 millimeter, then they can be given some medications to increase the chances of passing the kidney stones. Okay. And if patient has less than 5 millimeter, then patient would not need any medication. They're more likely to pass with increased fluid intake, urine output, they're most likely to pass the urine, a stone in the urine. So again, the pain control, the study shown that non-steroidal are better for pain control as compared to opioid. Again, make sure that patient doesn't have any risk for non-steroidal, like no chronic kidney disease or any other risk for that, no contraindication from that. This is a study which again shows same thing, that NSAID are better for pain control from kidney stones. So again, if a patient's kidney stone is less than 5 millimeter, then there's a very good chance that patient will pass the urine without much to do other than increase fluid intake, increase urine output. And if more than 10 millimeter, then there are very less likely that patient would pass the urine by itself. And also the kidney stone, the location also important. If the kidney stone in the ureter, like proximal ureter, so less likely to pass the kidney stone by itself. If the distal ureter, then there's a good chance of that, and the less than 10 millimeter, the chances are good that they will pass the urine stone in the urine. So medical therapy, like to increase the risk, the chance for kidney stone, there are two medication. If patient has between 5 millimeter and 10 millimeter. So one medication which is more important is like alpha blocker, like a tamsulosin, 0.4 you give for every day and wait for a few weeks, and that will increase the risk and chances of getting rid of the kidney stone as long as the patient has sizes less than 10 millimeter. The other medication is nifedipine, calcium channel blocker, that has less effectives compared to this, so tamsulosin, but also can be, I mean, I sometimes give both together if the patient not taking blood pressure medication, need to, if not some others. So calcium channel blocker and also tamsulosin that increase the chance of getting rid of the kidney stones or ureteric stones. So when the surgery is needed, obviously when patient has hydronephrosis and UTI, same time, risk for bacteremia or bilateral obstruction, obviously then patient needs some intervention. Or patient has one kidney and that is obstructed, in that case, definitely needs some surgical intervention. So these are again that surgical intervention when patient kidney stone is more than 10 millimeter big stones. And but again, a patient has less than 10 millimeter, but again, 4 weeks, 6 week stone is still there, then something need to be done. By intervention need to be done. And our patient has pain is unbearable, or patient is pregnant, from the observation is not very feasible. In that case, something need to be done surgically. So different options for surgery, like a common procedure is shockwave lithotripsy, but that is not be done in patient who are obese, or patient is pregnant, and or patient has uncontrolled bleeding problem. Those patients is a contraindication for lithotripsy on those patients. So what to do if the kidney stone is big, then very big, like more than 15 millimeter, then lithotripsy is not a good option. They have to go to percutaneous nephrolithotomy. That is the procedure. Obviously, we don't want to go in detail about that, but lithotripsy is not the option. But it's less than 15 millimeter and location of the stone, the upper middle pole, that actually is a good target for lithotripsy. Unless patient is not very obese or pregnant or bleeding diathesis, in that case, lithotripsy option. Otherwise, go to uteroscopy, or in that case, or percutaneous lithotomy in that case. So if patient has lower pole of the kidney, that is also not good target for lithotripsy. Again, same thing. The location of the is also important. This distal, these are for ureteric stones. If the patient has a distal ureteric stone, that is basically just like putting stent, or there is better options. But it's a proximal ureteric stones. Okay, then either you go by lithotripsy, or if there's a contraindication for lithotripsy, then you can go by uteroscopy, by putting stent and laser treatment and dissolving the stone and taking it out. So again, the special group, like patient with a very high BMI, avoid lithotripsy. Pregnant patient, avoid lithotripsy. Patient with the bleeding problem, diathesis, avoid lithotripsy. Again, the stone formation also, to some extent, like some stones are very hard to be dislodged or break down by lithotripsy, like particularly calcium oxalate monohydrate. But most of the time, the urologists, they don't know what is the. To some extent, they have idea from the CAT scan report which kind of stone they are dealing with, but there's no stone they will not try with the lithotripsy. There's no, oh, this stone we don't want to even try. No, they do try on every kind of stone, but some stone are less likely to be break down by lithotripsy, particularly brushite stone or calcium oxalate stone. So that was my brief, hopefully simplified presentation regarding kidney stone, their management. Any questions? Let me just.
Dr. Safar Iqbal, please go ahead.
Yes, thank you very much, Dr. Avais, for such a wonderful presentation on such a big topic. I really enjoy, and it was really.
Yeah, I tried to make it simple, and so I can have more time for question answer.
Yeah, sure. Yeah. Actually, I'm a nephrology working in Qatar, and I had was working in Canada, and then I had experience working in Pakistan, also Sheikh Zayed Lahore. So I just want to tell about the question Dr. Avais was asking, that there is a review of Gulf data about stone, and that was 2012. It was not very old. So more common stone is calcium oxalate, second uric acid, and the more common incidence here is high protein intake. 6 times oxalate is intake is high than the calcium, that lead to stone formation. And there's another risk of dry climate. So that's your first question you were asking, the data from the Gulf. And in the Qatar, there's high risk of obesity. So if you have time, 2-3 minutes, I can share my experience of 2 cases here.
Absolutely.
And, thank you. Actually, now I'm getting referral from urology to a patient. One is young and 35 years old, and he has recurrent renal stone from last 15 years. And surprisingly, both of them, creatinine is normal. And there's the young guy, he's 35 years old, and his stones analysis showing uric acid stone. I was looking for the causes for the stone, and there was no big thing. Only I found 2 things common in these 2 cases. Obesity, number 1, BMI was more than 31. And the other thing, myeloma screening was negative, as you were mentioning, myeloma and uric acid stone causing myeloma, that was negative. So for them, I mean, one question I want to ask, allopurinol, if in uric acid normal creatinine and no other reason, should we give in this patient for the prevention? that I want to hear from you.
Yeah, before you do that, what's the urine pH you are able to attain?
Oh yes, this guy is 5, is low really.
Yeah, that I would do first. I mean, how much potassium citrate he's getting?
Just this first visit, and I sent for metabolic screening for the workup, and still pending. I will wait, and then I will start. Yeah, if citrate is low, of course, citrate will help.
Yeah, two things here. I mean, before I go to allopurinol, obviously you need to do a 24-hour urine. And if the uric acid is very high, obviously you can start with, but first of all, I will see the pH. And if pH is low, then first thing you would like to do is putting potassium citrate and increase the pH 6 or 6.5 in that range. Okay. And obviously you will put him on a low uric acid diet, like increase whatever the diet can increase uric acid, that she should avoid that to some extent, and particularly meat and all those things. If uric acid, it does not decrease uric acid in the urine, then you can add allopurinol. But I would not start with allopurinol. But uric acid is the most important thing here.
And I was looking for the causes. So they have family history. He has family history of all family members have stone.
Oh,
is there any other cause like?
I mean, in that case, I think they have some like a xanthine metabolism, some abnormality that could be possible. In that case, you can start allopurinol in that case. But first, make sure that he also getting enough potassium citrate.
I was reading for this Lish Nehan. This I think is in young age, not at this age. What do you think?
Yeah, I mean, because pediatric nephrologists deal with those stuff. Luckily, we don't, but I don't have anything. But again, those patients who has family history of uric acid stone, if you know that they had uric acid stone, then I think allopurinol will be because probably they're forming more. You don't have a uric acid level, serum uric acid level yet?
Yeah, they have normal.
Normal.
Yeah.
Okay. So basically, in that case, urine pH need to be improved more than anything. And I would still
hydration. Yeah, right.
Hydration. We have patients who have normal serum uric acid, but they needed allopurinol because that's the only way to decrease their uric acid. So you can give that.
Thank you.
You're welcome.
Dr. Avais, Masud, there is some discussion in the chat about a question of the utility and mechanism of action of ACE inhibitor, especially captopril, for treatment of cystine stones. Yeah,
actually, again, I have not dealt with the cystine, but again, the captopril also have been shown to improve that, they decrease the risk for cystine. And yeah, they're, in fact, they don't have much experience on that, but that theoretically, their captopril, it is recommended to treat for patient also for that. So mechanism action, I don't know exactly what mechanism action, but I think I didn't look into it, but I'm sure that they have maybe got to be something their metabolism of amino acid of cystine from that. If somebody knows, then I'll be glad to hear from that. But definitely,
I think there is a comment, like an answer from Dr. Baligur Rahman Mahmood. If you are able to speak, would you please say something? I know you have a nice answer in the chat as well.
Yeah. Can you hear me? Right.
If you speak like closer to the microphone, it might be helpful.
The answer is basically from up to date, and the usual dose that is required of captopril is around 150 milligrams per day, which is significantly higher as compared to the doses that we would need to control the blood pressure. So tolerability is an issue at such high doses. So I don't know whether it is used in practice or not, but the doses required is significantly higher.
Yeah, that's why the other medication available now, you don't have to captopril, you don't go, that's why I don't know much about captopril, because I didn't hear anything that captopril being used for that. And we have the other medication available, which are much more effective than captopril, and particularly if the dose is required is 150, pretty high dose for that. Those medication I heard is pretty effective. Those two medication I mentioned, and the like D-penicillamine has more side effect, but other medication is very well tolerable.
Can you hear me?
Yes, we do.
Okay, I'm sorry, I think I was having some audio issues. So on the case that Dr. Zafar Iqbal was presenting, if you've got a young patient with a very significant family history of recurrent uric acid stones, I think what you need to screen them for is a UMOD gene mutation. So this is very specific and classic. Lesch-Nyhan syndrome is a problem where you can get uric acid stones, but it is associated with several other abnormalities. UMOD mutations, there's a spectrum of mutations which cause autosomal dominant tubular interstitial kidney disease. And, one of the cardinal manifestations is recurrent uric acid stones in several family members at a young age. And eventually, as they grow older, they develop chronic tubular interstitial nephritis and renal failure.
All right, I see. So the test usually genetic screening, how do we do?
Yes,
Can we do it?
there's genetic testing available, and you can actually do targeted sequencing because this is one gene with very well-defined canonical mutations. So you can probably, instead of doing a whole genome sequencing, which would probably be more expensive or prohibitive or availability limited, you could probably get targeted sequencing done. I know that some of these targeted gene sequencings are being done in Pakistan. I speak regularly to some of our colleagues in Pickley, where they're trying to screen for primary hyperoxaluria, etc., before kidney transplantation. So I'm pretty certain this can be done locally in Pakistan.
No, we have, I'm working here in Qatar. So we have the setup of screening. So no way.
Yeah, I mean, I
We
think
can do it.
resources in Qatar would be better than.
Yeah, we can do that. Yeah, that's a good idea.
I mean, that goes
Great.
with any condition which have any family history of any particular disease. Luckily, we have a lot of genetic testing available now, and that will resolve many issues. Yes.
Right, this is a very good. Yeah, good. Thank you, Dr. Afan.
Dr. Avais, which is better, allopurinol or febuxostat?
I mean, again, there was a study here to add. There is the uric acid was much more less with the urolic. Okay, that is what you call as compared to allopurinol. But the study eventually said that decrease in uric acid stone formation was equal. So, I mean, allopurinol is cheaper, and obviously you go for that. I mean, if there is some reason I have a patient who is allergic to allopurinol, only then I go to the other medication. But otherwise, there is no reason to not to be on allopurinol.
And there is another question in the chat box that urologists, they are using sildenafil in place of tamsulosin. In my experience, tamsulosin is still the best choice for lower ureteric stones. But I think urologists, they are proved to become urologists, so that's why they are choosing the advanced drugs, the new drugs.
Yeah, I mean, I'm not aware of any study which showed head-to-head, but again, it's a tendency that people who think that they are specialists, they like to have more fancy medication as compared to.
Yeah.
If you're sending patient on tamsulosin to them and they will not change, you say, okay, I send to specialist and the same which I'm doing.
Yeah.
But I'm not aware of any benefit of that.
Except the cost, right?
Yes.
Yeah. So I have one question, like as a nephrologist, how much workup we should do? Usually only the metabolic screening, prevention, and all this other parts urologists should do it, or just as a question, because in Canada, just we do metabolic screening and refer to dietitian, and that's it. Just we follow once a while.
No, believe me, because I, as a nephrologist, do a lot. Okay, and many times patient who actually they come to me more often than go to urologists if they are better, and the urologists actually like it because they don't want to deal with those where they have to their brain. They like to do a very skillful people, So no, we do a lot of workup, all the 24-hour urine. Then obviously you have to, manage that electrolyte imbalance. Very common medication is thiazide diuretics. Then we ask them to drink a lot of water. Actually, some patients end up having hyponatremia from that. Okay, and you have to manage those. And I have a dietitian, and I send to her patient, and that's very important also. But I think a nephrologist has more active role in management as a whole of the kidney stone than urologist.
Right. Because sometimes the number is quite high. So normal creatinine usually they follow in the urology. So if they need help, then they refer to us, So that's the.
Depends on
yeah, right.
In my practice, I get almost all cases are from urologists. They send to me, and I manage them.
So one of the best practices for the setup of the clinic, which we have, is the metabolic stone clinic, where we have 2 people who have high passion into this stone disease. So our program director, Dr. Ron Miller, he's the nephrologist and one of the urologists who exclusively wants to work with the stones. So they have actually clinic same time in the same building. So they have 3 or 4 rooms. So it's a multidisciplinary clinic, similar to when we do transplant clinic, when surgeon and physician sees patient together. So 50-50, half of the patients are seen by both specialties, half either of them based on their follow-up cadence. So then even I as a nephrologist, if I have a complex stone patient, I quickly refer them to our stone clinic, where they see urologist and nephrologist same day. They decide their images. Every year they come back with a there are protocols set up for 24-hour urine testing and medication changes. And then we have a dietitian somehow connected to that clinic as well. So that's one of the best practice. If, of course, systems, they have some leverage to arrange some of those clinical operations. But sometimes in real life, it's difficult to have those 2 clinics together in one space.
It's very rewarding also. Majority of the patient they are not that complicated. They're easy to be, they're correct their electrolyte abnormalities, and they're very happy. It does affect their formation of kidney stone or recurrent kidney stones. So they're very happy, and they're actually one of the probably most rewarding patients are, for me, is patient with kidney stones.
Yeah, I have the same experience. A patient who lives 2 hours up north, school teacher, she was told to go on dialysis. She came to me for second opinion. I connected her to stone clinic. They did multiple procedures, lithotripsy, stone extraction, etc., etc. 2 years later, her creatinine is less than 1.5. And then every time there's an appointment, she likes to send the whole clinic some flowers and some thank you notes and all that. So you're right, they are very, very grateful patients. To me, stone is a lifestyle disease in the right kind of genetic predisposition, in the right climate and environment, and the best remedy, which we fail to prescribe. So the cheapest and easiest remedy for stone prevention and treatment is water intake, increase fluid intake. So I tell my patients, drink every 3 hours. This is the trick I learned from Jamie Johnston, who's the program director for the UPMC Pittsburgh program. So he gave this advice to all of his patients. Like, you drink every 3 hours, even in the middle of the night, because when you wake up at 6 or 7 in the morning after 6-8 hours sleep, the morning time is the time when the urine concentration is highest. So that is the highest risk of stone formation. So he says, he told his patients, take a pitcher of water, put this on the bedside table. Before you sleep, drink something. 3 hours later, this will force you to go to bathroom, go pee, come back, drink again, sleep again. Now you drink some water every 3 hours. And that trick, at least in theory, in practice, in practical life, does work. So it's really a lifestyle change. You mentioned salt intake, protein intake, which are actually more important than looking at the calcium and oxalate things. So water, dietary restrictions, lifestyle modification, prevention of stones. So if we don't have any other questions, maybe we can go, and I'm just anxiously waiting for.
I'm looking for a question regarding. Let me see. That was very important. Like, I reached low citrate level or something like that. Okay, in most of our patients, we have low citrate level, more commonly idiopathic, and less so with RTA. What is your experience? I mean, my experience is that RTA is a very problematic patient to deal with because they actually have calcium phosphate stone, okay, because their pH is high. And many of them, if you have very, very low citrate, I mean, because in the urine, I mean, like almost undetectable. Okay, the reason being that when there's metabolic acidosis, it increases your reabsorption in the proximal convoluted tubules. And obviously what to do, if you go potassium citrate to them, that can increase their urine pH, that increase the risk for calcium phosphate stone. If you don't give citrate, then what to do? So that actually my experience is that all RTA patient has very low citrate in the urine. So not the other patient like idiopathic or calcium oxidate stone. And sometimes I don't know what to do. And then that helps me that 24-hour urine and supersaturation. So if patient has supersaturation for calcium phosphate stone, obviously I like to keep the pH low. If not that low, then obviously you have to balance between citrate giving them and keeping their urine pH. That's more very difficult patient to deal with. I don't know how you guys do with that in that situation. Your pH is already 6.5 and urine citrate is almost not detectable. No idea. Okay, go ahead. If any other question, then we want to. Omar.
No, I think I was just wondering, like, if if we switch gears and waiting to hit
The other question, other important question, like now the SGLT2 inhibitors, they are very commonly prescribed. So some patient asked me that, okay, I'm taking this medication, that increase my risk for kidney stone, or it will decrease that. Anybody has any idea? Like patient taking Jardians and taking Farxiga, what are you going to tell them? The patient has history of kidney stones also at the same time.
Don't know the answer to it. It's a good question, but it increases the osmolality of the urine, right? So your urine is hyperglycemic, it's more concentrated.
Actually, there was some study recently came out. It showed that there is 40% decrease in the kidney stone formation probably because increased urine output, and that's the reason they mentioned that actually. So just if your patient asks that it will increase or decrease my chances of a kidney stone, so it's not to be discouraged. I mean, they actually decrease the risk for kidney stones.
That's a great answer. I'm sure SGLT2 are the buzzword for
Yes.
everything between diabetes and heart failure and CKD progression, IgA, and now the decreased risk of kidney stones. Wow, that's magic.
Yeah, I have to be a little more detailed about good study because these are so commercially, I mean, of course, those driven, these are like, they're like every time I'm sure anybody's office, they're patient either from Giardians or Farxiga, they're coming to you. And so I have to see more evidence on that, but just small studies show that.
Good.
Okay.
Do you want to give us like a background of your patient first and then give us the answer?
Exactly. So this is a patient, 75-year-old patient who was admitted 5-6 days ago to our hospital with complaint of generalized weakness and not feeling well. And she said she has a diarrhea off and on for almost a month. And so when she came, her creatinine was 5. And she has some leukocytosis also, like she has 22 of WBC count, no fever, nothing. And she is from New Jersey, where I am, but she lives in Bahamas. Okay, she retired, so is there. And she has only history of hypertension. Before that, she denied that any history of chronic kidney disease or anything else, any heart disease. But she said like about 6 weeks ago, she was admitted to Florida for what she described sepsis and pneumonia. I couldn't get much detail about that hospital, maybe some small hospital. But then she was discharged on Augmentin and doxycycline, which she said she took for 3-4 days, and she was supposed to take longer, but she did not take. She didn't like it, so she discontinued. So we were able to get some previous blood work. So her creatinine was actually normal when she was discharged from that hospital. So everything is new. So she looked dehydrated when she came. We thought, let's give some fluid. Then maybe that's dehydration caused that. She was given fluid. And with that, creatinine came down a little bit from 5 to a little bit 4 something, but not more than that. Blood culture, urine culture was negative. Kidney ultrasound shows no obstruction, although maybe that's maybe a little bit high echogenicity, but probably that's not important. So nothing. So after that, she has hypertension, and the only medication she was taking on a long-term basis, indapamide, low dose, I think 1.25 with some ACE inhibitor, which is more like over there, some ACE inhibitor, nothing else. So that here she comes, and she had urine short, she had some WBCs, she had some microscopic hematuria, she has a urine protein concentration of 2.8 grams, and all the serology came back negative. ANA, double-strand DNA, complement, everything came back negative. Culture was negative, urine culture and blood culture negative. So creatinine improved, but not much. So like 3-4 days later, like 4.2. Actually, today is a little bit better, like 3.8, which is improvement. She is non-olivuric. She looks comfortable. Her diarrhea has subsided. There's no C. diff colitis. So here she was. So, and then ANCA came back. ANCA showed that C ANCA is pretty significantly high, like 300, more than 300. But her PRE3 negative and MPO is negative. So question was that, what is that? Is that vasculitis? Is the vasculitis why the MPO and PRE is negative? And it doesn't look like rapidly progressive glomerulonephritis either, because the creatinine actually coming down a little bit from 5 to 3.8 now. She's non-olivuric. So if she have vasculitis, we are supposed to start on some treatment, like aggressive treatment, like pulse steroids or rituximab or cyclophosphamide. And so we did the biopsy. It was done yesterday, and I was expecting the result to be back tomorrow, but luckily we got it today. He called me today. He said, I'm off tomorrow. So I went to see the biopsy today. You mind not talking to you on Sunday? I said, I would love to. So here's the biopsy finding. He said the biopsy was very kind of busy biopsy. And there were 26, 23 actually, glomerulus he saw. And he said that, first of all, like 4 different diagnoses, but here there's no question that this is a positive immune glomerulonephritis. Okay. Yeah. There's no question. I said, whatever your ANCA showed or this and this, okay, this biopsy overtake everything. I said, that's fine. So at the top of that, there are like signs of ATN. He said there's tubular necrosis over there. And then there is a lot of neutrophils, not eosinophils, interstitium. That looks like some active infection or infection-induced, some going on. And then some vascular, he said he saw some emboli, probably cholesterol emboli in the vascular. So he said 4 things, like a positive immune that is predominant diagnosis. And then some ATN, then some neutrophil infiltrate. And then he said there was 6 crescents also, like cellular crescents also in that. So that's the biopsy report.
Okay, so the issue is tissue, gold standard.
Yes.
Now we are thinking as like what to do next.
But he said no. He said he's a very famous. I'm sure probably Irfan knows. He's very famous. I think in this area at least. Markowitz, Glenn Markowitz, is a very like a well-known renal pathologist. He said, but make sure that patient doesn't have endocarditis, or because it looks like some look like more like an infection-induced. I said no, culture has been negative, but that he sees a patient with the endocarditis, many finding in that too. So it's not straightforward. Okay, he said, what do? You would do the immunosuppressant. I mean, sometimes he does clinically, like his good opinion. I said, that's not my job. That's your job. How you treat that? I gave you the diagnosis. Okay.
So was there any instrumentation like a heart cath or anything peripheral vascular
No.
in the last 3 months, 6 months?
No.
Okay.
No history of cardiac disease. Irfan, I'm sure you're itching to talk about that.
So do I. So let's have Dr. Aha's opinion first.
Let's start with Dr. Ara.
Yeah, so I mean, we've had a lot of conversation on ANCAs and their interpretation on our chat as well. So let's kind of recap some of that. The first test that came out to look for ANCAs was the indirect immunofluorescence test. And essentially what you do in this is solubilize because the antibody has to reach inside the cell, right? Because these are intracellular antigens to which you're finding the antibody. So you solubilize the cells by using ethanol or something. So usually the indirect immunofluorescence is done on an ethanol prep. And if there's antibodies to some of these antigens, they will light up. The antibodies can be targeting many different antigens. So myeloperoxidase and PR3 are the common antigens that we know of. And the reason we look for these antigens on the ELISAs is because these are the antigens which have correlation with kidney disease. So in the 80s to 90s, ELISAs started becoming available because there's a wide variation in how the indirect immunofluorescence is interpreted. And there's many different techniques for ELISAs as well. So the first 10, 15 years, the ELISAs were up and down also. And therefore, the initial recommendations were to do an indirect immunofluorescence as screening and then confirm it by running ELISAs against PR3 and MPO. If your immunofluorescence was positive, but the ELISA was negative, then the immunofluorescence was put into question because it is sensitive, but it is not as specific as the ELISAs. And over the next 10, 15 years, as the ELISA techniques got better, the predictability, the sensitivity and specificity of the ELISA tests got better also. So in 2017, the level of confidence on the ELISA was such that they recommended that you don't need to do an indirect immunofluorescence, but it is done pretty much every lab that I know of, every hospital system that I know of. When you send an ANCA, they first do an indirect immunofluorescence. If that is negative, they stop. If it is positive, then they run the confirmatory ELISAs using a PR3 or MPO. You can order the ELISA straight away, but sometimes the hospital systems would block that and would run the immunofluorescence first and the ELISAs later. So this creates a category of tests that are positive on the indirect immunofluorescence and are negative on ELISAs. What are those tests representing? So some of them are clear false positives, right? High level of ANA, and then some other things can cause false positive indirect immunofluorescence tests. Most of those are in the p-ANCA pattern. Very rarely do you see a c-ANCA false positive. So then you have to turn back and say, okay, my gold standard is an ELISA. What is the specificity? What is the sensitivity of that ELISA? And if your ELISA is a direct ELISA or an indirect ELISA, the sensitivity of that is in the high 80s. So there will be about 10 to 12% of cases that are true positives that your ELISA might miss. If it is a double sandwich ELISA, then your sensitivity goes up into the high 90s. And so the chances that that would miss a true ANCA goes down low. But there is another whole group of ANCA antibodies that are true ANCA antibodies, but are neither PR3 nor MPO. So one of them at least is nephrotoxic, and that is the HNE antibody, the human neutrophil elastase antibody, can cause kidney disease. But most of the others the so-called X-ANCA or A-ANCA antibodies are generated mostly through GI disorders. Now, ANCA are very commonly seen after infections. So it is not that if you see an ANCA antibody in the blood, that automatically means that the patient has ANCA vasculitis. And the commonest infections are sepsis and infective endocarditis, where you would see some of these antibodies float around. They come and go. They usually are not going to cause kidney disease. So that's the background. You know, if you have ANCA antibody, that doesn't automatically mean that there's kidney disease. Similarly, if you've got ANCA-associated post-immune vasculitis in the kidney, you can have it without demonstrable ANCA antibodies in the blood. So all of these things have their own diagnostic confidence intervals. So if you combine indirect immunofluorescence and proteinase 3 and MPO ELISAs and just run them on everybody, you're gonna have not just false positives, you're gonna have ANCA-associated antibodies registered in many people who don't have any disease whatsoever. So this is why you have to gate these tests, you know, in patients where the answer is of a high degree of likelihood. So a Avais patient would actually drop into that bucket where they've got kidney disease already, and we're really concerned that there may be small vessel vasculitis in that patient. So how do we parse through a Avais patient here? So the reason it was concerning, and if this was a PN cut 1 to 320, I would tell you just forget it. I mean, this is just a false positive. But CNCAs you have to respect, because you have to entertain the possibility that this is a true CNCA which the indirect immunofluorescence is picking and your EIA is not picking up. So that is one issue. The second thing is this patient has been very sick, has been septic, and has every reason to have a transient ANCA in the blood. But then she does have post-immune vasculitis on the kidney biopsy. Now, if there is a gold standard out there for, you know, to pick up kidney vasculitis, it's a kidney biopsy, and Avais has done that. So the diagnosis that this patient has post-immune vasculitis is not in doubt anymore. Now, what is driving that? Somebody mentioned that we could probably stain for ANCA on the kidney biopsy. Again, it bears reiteration that this is a post-immune process. What that means is you're not going to see antibody in there because the ANCAs are not depositing in the kidney. The neutrophils are charged in these cases, and the MPO and PR3 targets have translocated to the surface of the neutrophils, and ANCA antibodies then ligate these antigens on neutrophils and cause neutrophil-mediated reactions. This is why you see, and the neutrophils have a lot of elastase in them, and that is why you see a lot of fibrinoid necrosis. That's what the vasculitis looks like, and that is why you see crescents, because those elastases melt the basement membrane. So the million-dollar question here is this a C-ANCA-driven process in somebody who I suppose had normal kidney function a few weeks ago and has had several infections? Is that right, Avais?
Yes, yes.
Mm.
So on January 7th, her creatinine was 0.7. Those came to know now.
And then is this a true CNCA mediated process, which is leading to rapid deterioration of kidney function and fibrinoid necrosis? Or is this an epiphenomenon on top of infection? And so the only infection that I know which can do this in this part of the world is infective endocarditis. There's a lot of data on TB in our part of the world, in Pakistan, India, Bangladesh, where you can see ANCA antibodies and discordant ANCA antibodies in patients with tuberculosis. But in Avais' patient, I think they had significant sepsis. Endocarditis needs to be, and the way I would exclude endocarditis in that Avais is that I have picked up actually PIGNs by forcing people to do TEEs. So you probably want to get a TEE before you start immunosuppressing this patient. So you want to make 100% sure there's no infection, there's no endocarditis, there's no vegetation, because blood cultures are going to be negative, especially if it's a low virulence organism, because she's had so many antibiotics going in. So once you've excluded infection and she's looking like she may be able to tolerate immunosuppression, and your repeat ANCAs are positive and the kidney is not getting better, and you have a window of 3 or 4 days to kind of start working on this, then you can probably consider some immunosuppression. But I'm still not 100% confident that this is not an infection-related event. But this is my thought. I would really, this is a really gray case here, so I would welcome other thoughts. And also, as other people are going to a point, Avais, can you look up what kind of ELISA they did? Do they mention that?
No, I posted the picture of that test. I don't think they mentioned that, what kind of. But again, you're right. Blood culture could be negative because she has been taking a lot of antibiotics. And the moment somebody with the WBC is 22,000 hit to the ER, they always give antibiotics over there. I'm sure she received antibiotics for at least 2 days. And I don't know what time the blood culture was drawn, maybe same time before they gave or after that. So I totally agree with you that I would definitely, because I mean, pathologists, he actually emphasized, okay, he could not stop talking about, like, make sure that you rule out endocarditis. I've seen this, many patients like this. So, and you are also, I agree with you that I would not start right away pulse steroids right now. I mean, I will definitely have a time, couple of days. I'll do the TE, just rule it out. But no, I don't know which kind of ELISA they did.
So typically, I have had some similar experience, but not as extreme. Like you came back with 4 diagnoses or 4 diagnostic, dimensions. Anytime the ANCA has this question of false positive, we learned that, like, for example, you have had the ANCA with positive ANA. I think we discussed that as well. And then whenever there's a question, the infection is always in the background. And this is what we discussed in our previous session when we did I think, Dr. Masud, you did the post-infectious GN session.
Yes. Mm-hmm.
Then we discovered and we shared that, sometimes you just see a background ANCA in these patients.
Yes.
So, I agree. I think approach is the same. That's why when I asked you, the first question was the echocardiogram to look for, and then ANA to make sure that this is something real or something just as a confounding factor. Approach, Dr. Agha really explained very well. The other thing is a thorough physical exam to make sure there is no joint, like in the back spine, where their infection might be hidden. The experience has been that if somebody has bad infection, it would have been obvious by now, but you can still have those occult infection in their spine, sometimes in the gallbladder. But I think this endocarditis and the spine are the 2 sources where I just actively go and forward. I mean, you want to look at in that patient, ask them to do to make sure there's no dental abscess. I mean, those are the things.
Oh, hold on 1 second. This is very important. I'm glad you remind me. The infection she started, she basically was admitted to Florida Hospital from the dental abscess.
Here we go.
And then she led to sepsis and pneumonia and all this. Okay.
So what if there was a transient bacteremia, dental abscess, transient bacteremia? What if there is vegetation now, or maybe there is no vegetation formation because she's treated or partially treated, but it triggered the immunological response. And that immunological response in the form of ANCA seems to be real. It has caused inflammation in the kidney, and it's post-immune. It's not lighting up like as you see in MPGN or post-infectious. So we have to respect both. Rule out the infection thoroughly first, give some time, let the jets cool off, and then bring the immunosuppression for the kidney. This would be my approach as well.
And she said the infection was so bad oral because she was not able to eat much and she lost significant weight because of that. So it was not like mild, so she has significant infection, oral infection, teeth infection.
So she needs a good dentist as well.
Yeah, I guess there's not much in Bahamas. Very.
Or maybe we have used very bad instruments also, dentist. That can also produce some infection from outside.
You're right. I mean, believe me, I don't know. I mean, if you've been to Bahamas, I mean, or
Yeah.
Caribbean countries, I mean, they're not very developed in some places. I mean, they are very developed in tourism.
Yeah.
But if you live there, they're
Bad.
they're not that great.
If this patient could have been here in my city, and we will not do any test, and we will go only to the antibiotics, meropenem, 500 milligram TDS, and the supportive treatment. That's it. And but you people are doing so much study, which is not possible, I think, in my city. Really.
But again, we can share all those our experience and something we learn from you guys. I mean, you do things which we don't do here.
Yes.
It's like common learning from each other. Yes.
Yes.
Sorry, the infection is still there. How severe is the infection?
No, I mean, infection is apparently not there because blood culture is negative. But when she came, she has leukocytosis 22,000. She was no active infection apparently going on, but we are not 100% sure there's no infection. I mean, underlying infection going on. So that's why you're going to do some more tests like a TE and make sure, as Dr. Umar Farooq mentioned, that make sure there's no spinal infection going on, because she had a very significant oral infection that can lead to anywhere.
Right, and in the kidney, there's no picture of infectious like.
No, there is actually. He said that there is some there's some picture which looks like an infection-related gene. He said there's a 4 diagnosis possible in that, but mainly he said positive immune glomerulitis, but there's some increased neutrophil infiltrate, but not eosinophil. I said there's a chance that patient has acute interstitial nephritis. He said no. Absolutely not. It's not a interstitial nephritis. It's more like a inflammatory, like infection-related glomerulitis could be one contributing factor at least.
Right. Suppose infectious could be, yeah, it's one of the possibility.
We have a suggestion from Dr. Abdul Khan about leptosporiosis can cause TIN. So I think the ID needs to see this patient with the specific request that we are looking, we want to look for infections proactively and some of these things.
We had a case last year with the leptospirosis causing GN. Yes, in fact. So you're right. Yeah, I will have an ID to see tomorrow. I will not jump into immunosuppressant as yet, but at least we have some idea what to do. Until yesterday, I didn't have any idea.
And if please allow me to say something more. One of the benefit for our sessions is this interactive discussion and the critical approach and critical thinking. So we all started with different multiple possibilities, and I think our thinking and approach to patient evolved as we were getting more information. But this is how we learn from each other, the ideas and the experience and the evidence. So when we combine, I think this is where we develop and utilize our critical thinking. So thank you very much. This is now we kind of, from your case, I'm sure is shaping my approach for if I encounter some similar cases in future. So thank you very much for sharing those cases and having these candid discussion with a lot of candor. Thank you.
Yeah, great. So again, back to kidney stone. I think that we will learn more from experience and cases. So next week, let's bring out some cases. We will learn from that. I'll bring a couple of my cases, but let's talk about the cases, and I think we're going to learn about that. I kept my discussion very simple, like a very basics. But when it comes to cases, I think we're going to learn from each other more. I'm sure everybody has cases, kidney stone cases.
And if anyone wants to present and wants to, you can send me a message in the WhatsApp, and we can, maybe make some slides or something. We can just present your case in that way. So it's sometimes easy to do that if there is a slide presentation. Even 1 or 2 slides is fine. I mean, if you send the information to me, I can make that. Okay, it looks like that time to conclude our today's session. So thank you, everyone. Looking forward to see all of you next Sunday.
And
you.
thanks, Elibor and Irfan, especially thanks to you for explaining all those background of the ANCA. I really know more now than I knew half an hour ago. Thank you very much.
Irfan, Dr. Agha, if you want to say something in the end, I know you unmuted yourself.
No, I was just trying to thank everybody for a lovely session, and especially to Avais for a wonderful presentation.
Thank you.